So thank you, Robert, for introducing the concept of Poseidon. And I will try to talk about how to manage Poseidon groups 1 and 2. I'm talking about patients that apparently have a very good ovarian reserve, but during stimulation, they have less follicles growing than expected, or at the end of stimulation, less oocytes than expected. So we can say unexpected poor responders or suboptimal responders. So I decided to give an angle. In this case, the angle is the LH and gonotrophins in general, because in these patients, we have a good ovarian reserve and the stimulation was not consistent with the expectation. It means that we can improve something with another stimulation, increasing the dose or adding a LH or moving from agonist to antagonist. We can change the stimulation protocol. The scenario is totally different in patient having a very low ovarian reserve, because if the ovarian, meaning patient groups 3 and 4, because if the ovarian reserve is very low, probably no gonotrophin can change the number of follicles. Here, in a second stimulation, you can change something. And my observation angle will be gonotrophins in general and a focus on LH. I will better characterize the I can say concept of hyperresponser that Robert mentioned before, and I will show you why we could change the gonotrophin administration in a second cycle in case of hyperresponse, and I will provide some clinical information on this. But before starting with this observation, with my presentation, I have a question for you. If we have to understand if a given protocol, a gonotrophin, LH in particular, is able to change something in our clinical practice, what is the best endpoint? The best endpoint will be live birth rate, cumulative live birth rate. I don't know, but what we have to understand is how can we say that a given protocol, a given gonotrophin is giving maximum results in a given patient. So for trying to reply this question, I have something to show you. This is the beginning of a football match. So my question for you is even more complicated than the question I had before on the capital of Singapore. So you saw 5 seconds of this match. So scan. My question is very difficult. Which is the probability that the white team would score a goal in the first 5 minutes? I think we can see the result. And so 61% of you are in agreement that it is not predictable from 5 seconds of the first kickoff of the match. It's not predictable. So I would like to know people that say 50% and even less than 30%, because I think they have an incredible talent for understanding which is the stronger. But I have a second question. Let's go for a little bit on, and let's imagine that from this football, we move inside the follicle with FSH and LH, white. And so now we have this follicle that is growing during our stimulation. My question again, obviously we are kidding, but my question again is, which is the probability that this follicle will give a live birth? So how can we say that the follicle will give a live birth? How can we predict which is the probability of live birth only watching that follicle during our follicle? I'm very curious to know the result, but I think that also in this case, it's not predictable. But there are people even more able to read follicles more than football teams because the quality of the follicles seems to be very good. What I would like to say, and I like to kid with this kind of observation, is that we have to pay attention when we read literature, when in the moment we have to give right interpretation to a given meta-analysis, in the moment we have to analyze randomized controlled trials, or even if we want to design randomized controlled trials, we have to be very careful and very, I can say, uh, uh, pay a lot of attention in the right interpretation of the results. So let me tell you something. This is a very nice meta-analysis that has been published a few years ago about the use of LH in the general population. All the trials available at the moment comparing FSH alone with a combination of FSH and, in this case, recombinant LH. Have a look. 36 randomized controlled trials with information deriving from more than 8,000 cycles. So it's a huge population for having information. So let me tell you what are the results of this meta-analysis. The results of this meta-analysis, having a look to live birth rate, is that there is not sufficient evidence to clarify if recombinant LH increases the live birth rate. Insufficient evidence to prove. But let's have a look to the results. We have 250 observations in one group and about 250 in the other group. So the information concerning live birth rate is provided only in 500 cycles, 500 out of 8,000. So 8,000 cycles analyzed, but the information on live birth rate is provided only for 500. Why this observation is important? Because 500 in a meta-analytic approach is nothing to say that there is or there is not an effect of a given protocol. So the conclusion is correct, insufficient evidence to prove. But this is totally different from telling you there is evidence that it doesn't work. One thing is to say there is not sufficient evidence to prove that something works, and a totally different thing is to say it has been proven that it doesn't work. And the sample size related to live birth rate is very small. And live birth rate is very far from ovarian stimulation. You have 9 months pregnancy. You lose patient during follow-up. You have a lot of lost information, but you also have so many events. So in my opinion, understanding if a given gonadotrophin is able to impact on live birth rate is like understanding from the first kick if a given team will win the match or not. And if you have a look to these results, the heterogeneity that we call high square is very high, meaning that we have a few cases, only 500, in very, very heterogeneous subgroups of patients concerning live birth rates. I think that we run the risk of mixing apples and oranges, because if you have 4 trials with a very different study population, it's quite clear in my mind that we cannot have any clear and readable conclusion. Let me tell you, if we want to know if a given protocol, in this case, LH, but we can tell the same, we can say the same for any given gonadotrophin, you have to consider that if you want to have to evaluate an effect of a given gonadotrophin on live birth rate, you should have probably more than 2,000, even 5,000 observation per group. If you have a look to the last ESHRE guidelines on controlled ovarian stimulation, there is no stimulation that seems to modify in a significant way the live birth rate. N-gonotrophin is associated, not recommended, not sufficient evidence. Why? Because we are using probably not the right system. Because if we have live birth rate as endpoint, we need two huge simple sites. And either with the meta-analysis or multicenter, with the multicenter trials, this kind of approach cannot overcome the problem because the inter-center effect is too high, too many confounders for having this information, matching results from different centers in randomized controlled trial. So I have the last question for you. Have a look here. So now the question is quite easy. So what is, in your opinion, the probability that this ball will go into the net, that this guy will score this goal? So I think that in football, we are very experienced, more than. So if we have a look to the result, probably in this case, we will have something different. You can see that 80%, 65% of you say that there is a very high probability that this ball will go in the net. And that this is correct. Why? Because the two events are very close to each other. So you can evaluate the impact of that guy on the result of the match, because the two events are very close to each other. So let's come back to the same meta-analysis. The same meta-analysis. So here we have an information about ongoing pregnancy rate. And you see that in this case, the meta-analysis provides information from more than 1,500 patients per group. So the sample size is larger. The heterogeneity among results is very low. The I-square is 2%. So results are very homogeneous in huge sample size. And there is a significant increase in ongoing pregnancy rate. So the conclusion of a meta-analysis is no difference, no sufficient evidence in 500 cases, because we decided that live birth rate is the ideal endpoint. But we have just in front of us the effect on ongoing pregnancy rate in a huge sample size, which is very strong. The p-value is very low. The heterogeneity of result is very low. The sample size is huge, and the effect is evident. But the conclusion of the meta-analysis is that there is no sufficient evidence because live birth rate is the king. Live birth rate is the ideal endpoint, I agree, but I think is not consistent with the sample size we usually manage in studies in randomized controlled trials we have in our scientific community, because the sample size, in my opinion, is difficult, that is adequate for having this kind of endpoint. So I took some time for telling this, and this is another nice observation from a meta-analysis from more than 500 by Daniele Santi, from more than 5,000 observation. And you can see that the association of FSH and LH does not have so much impact on the number of eggs in general population. But if you move to implantation rate and pregnancy rate, the association of FSH and LH increases the pregnancy rate. The problem is that we lose patients at the follow-up. We don't have adequate sample size for live birth rate. But we don't have to run the risk of not seeing something just because we look very far and we don't look to what is very close to our eyes. So I will go very fast on the other points because my time is not so much. We have just 5 minutes. This is what Robert was telling, Professor Fischer was telling before, that we can have a patient with a similar starting point, similar antral follicle count, similar demographic anthropometric characteristics, but they show totally different sensitivity to standard doses of gonadotropin. These two patients have, we can say, totally different ovarian response moving from the same point. So in this case, the sensitivity of the ovary was very good, we can say normal. In this case, the sensitivity of this ovary was very low. So despite normal doses, standard doses of gonadotropins, only 30% of follicles reached maturity. So this is the concept that has been explained before, the concept of hyperresponse. So the prognosis is related to the number of eggs. So if the number of eggs is between 4 and 9, we can say that this is suboptimal responder in terms of prognosis. If we have less than 4 oocyte, we can say that she's a poor responder. But what is important is not the number of eggs. What is important is the number of eggs consistent with the potential of that patient? Because if it is consistent with the potential of the patient, I don't have to change nothing in the eventual second stimulation. But if the ovarian response is below the potential of the patient, I have to change something in my second stimulation. And this is the case of group 1 and 2, meaning a patient with a good ovarian reserve that following stimulation had less follicles growing, less oocytes than expected. And so why should we consider the possibility of using LH in a second stimulation? I will very fast on this. This is the classical model of two gonadotropins, two cells theory. According to this model, we know that LH is very important in inducing the production of androgens in TICA cells during early stages of folliculogenesis. The androgens move to granulosa and they are converted by aromatase in estradiol, and the aromatase is under the control of FSH. So it's cooperation. LH induces androgens are converted in estradiol. But what is very important, and it has been discovered in the last years, is that granulosa cells also express LH receptor in follicles overcoming 9-10 millimeters. So when you stimulate your patient, you see follicles 10-11 millimeters. These follicles have LH receptors also in granulosa cells. But granulosa is not involved in androgen production. So we have to hypothesize that the same molecule, LH, plays different roles in TICA cells, producing androgens, in granulosa cells only of dominant follicles, supporting the FSH activity. So they work together, FSH and LH in granulosa cells. They can even substitute each other. It has been proven that if you start stimulation with FSH, once follicles overcome 10 millimeters, you can even support last stages of stimulation only with the LH activity, because there is, we can say, the dimerization of the receptors. So these are FSH and LH receptors in granulosa cells, different receptors, different gonadotropin, but they converge in similar transduction pathways. And these pathways, and you can even have dimerization of the receptors. This is very important because the cooperation of the two gonadotropin is crucial in our clinical practice. Because if you have a patient with a very good ovarian reserve, you give FSH, follicles don't grow as expected, you can hypothesize two things: that something is wrong in the FSH system, or something is wrong in the LH system. You don't know it. So what you can hypothesize to do if the growth of the follicles is not consistent with the expectation, during the cycle, if you are in time, or in the next cycle, you can do both. You can increase the FSH dose for pushing something in the FSH system, and you can add LH because adding LH, you can overcome problems in LH system, LH polymorphism, LH receptor polymorphism, but giving LH, you can also support FSH and helping FSH in overcoming something wrong in the FSH system. So if we go and I complete in the clinical practice, we have always to hypothesize that if we give some LH activity, and I will prove it with some trials, if the system is not working properly, with LH, we are potentiating the activity of FSH in the paracrine network in granulosa cells at the moment when follicles are overcoming 8-10 millimeters. So what we have to keep in mind is that if we give LH since the beginning of the stimulation, we are pushing on androgens, and we can have an impact on recruitment, because improving androgens means improving the expression of FSH receptor. So LH from day one means improving recruitment. If we continue with LH during follicular growth, from a given moment, LH will support FSH in granulosa cells. So at this stage, we are improving survival and quality of granulosa cells. So the moment you give LH has an impact on the effect of the gonadotrophin in your stimulation. So I take the last minute to tell you that there is evidence, in my opinion, in general literature, that if you have hyperresponse, group 1 to Poseidon, having some LH activity, you can improve the recruitment, you can improve the quality. And this is the SPART trial, comparing recombinant FSH alone with the association of recombinant FSH and recombinant LH in poor responders. Here, the endpoint of the trial was the number of eggs retrieved. And here, the study population was selected according to Bologna criteria. As a result, in the study were selected very, I can say, bad responders, patients between 39, 41 years, 40, 41 years of age, with very low ovarian reserve. Aneuploidy rate is very high in this group of patients. So if you have a look to the number of sites, the study failed, no difference in the number of sites when patients were selected according to Bologna criteria. But when we tried to meta-analyze, to have an analysis of data concerning the association of recombinant FSH and LH in low prognosis patients stratified according to Poseidon, we analyzed all the studies where the LH was utilized in case of low fort. In all cases where during stimulation, when the authors realized that few follicles were growing, they added LH or they used LH in the next cycle. So not in poor responders, but in patients consistent with the group 1 and 2 Poseidon, meaning good ovarian reserve, but ovarian response lower than expected in the current cycle or in or LH has been given in sequence cycle. And let's have a look to what we found. When patients were selected as hyperresponders, we found that the supplementation with recombinant LH significantly increased the number of eggs, meaning recruitment, and significantly increased the ongoing pregnancy rate. So you can tell the sample size is not so huge, or you can tell information about live birth rate is not provided. But I think that clinical implantation rate, clinical and ongoing pregnancy rate are very important indicators, because the results are very consistent each other. So this is the right track for future research. And what is important, the ongoing pregnancy rate is very close to the ovarian stimulation. And only 1-2% of a patient overcoming 10-12 weeks of pregnancy will have abortion in the following weeks. So I think that ongoing pregnancy rate can be very representative of your results in your lab and your clinical practice. And if you stop your observation here, you can find that there is an effect. So just to conclude what I said, in general, if we want to evaluate an impact of a given gonadotrophin, the ideal in every kind of population, the ideal obviously is live birth rate and cumulative live birth rate. But we run the risk of a sort of waiting for Godot. So we want to evaluate the effect on live birth rate, but the sample size will be always insufficient. So we run the risk of not seeing something that is very close to our nose. So I think that when we have a Poseidon group 1 and 2, what is important is understanding if the ovarian response in next cycle is consistent with the expectation. So FORT and FOI are very important endpoints in the practical daily life. And I think that if you want to have a look to your lab, what happens, and to your IVF unit, I think that ongoing pregnancy rate is a very good indicator, in my opinion, of what's going on in your clinical practice. Anyway, at least one meta-analysis showed that LH supplementation can increase ongoing pregnancy rate in general population. But if we focus on groups 1 and 2, Poseidon, meaning a patient with unexpected impaired ovarian response, which is probably a genetic trait, a recombinant LH supplementation is able to improve in this kind of a patient, group 1 and 2, both initial recruitment, FORT, FOI, and even ongoing pregnancy rate. So I thank you for your attention, and I thank all the people in my staff.